welcome Dr. Anjali. Today's first speaker is none other than our own Dr. Anjali Bhatt, a bright young endocrinologist from the city of Pune. You have been hearing her with her very passionate science throughout the past day. Welcome to you, Anjali, and over to you for your topic.
Thank you so much for the wonderful introduction. And we have an interesting session in the morning. And the first talk is going to be transitioning from traditional to a personalized care with iPDM. I think we have come a long way from the understanding about diabetes as a disease it's divided into type 1 or type 2, where there is insulin deficiency, insulin resistance. We have come a long way from there to understanding that it is a collection of extremely heterogeneous people, which might start on one end as people who are born with severe abnormalities in carbohydrate metabolism, not only in insulin, but also at the level of glucagon or at the level of the periphery. And then we have again a heterogeneous group of a large population, which we call as type 2 diabetes. And there are a number of pathophysiological factors that are involved in the way these people respond to your treatment. So it starts from insulin resistance to relative insulin deficiency to insulin dependence, to factors like nutrition, the exercise, the mental status of the patient. There are things like drug response, drug non-response, compliance, non-compliance, the lack of understanding and excessive awareness because of social media and available resources on the internet, which the authenticity of which can always be questioned. So what we have now understood about is that there is not going to be anything which will have one size fit to all. And from the traditional guideline approach, where we had an approach that, okay, this is the level of glucose above which we call it diabetes. We start on drug A called metformin. If it doesn't work, we call for another drug to be added to that, then so on and so forth. Now we know that it's not as simple as that a protocol made from step 1, step 2, step 3, step 4. It is almost like we have 7 billion types of diabetes and 7 billion types of people around us. And everyone needs to be taken into consideration as an individual patient and not just as a disease called diabetes. So with that, we are going to have a talk today. Let me in the beginning put a disclaimer that this talk is brought to us by Roche, and the talk is called Transitioning from the Traditional Care of Diabetes to a Personalized Care with Integrated Personalized Diabetes Management. Now, this is one of the approach that they have shown that works in better management of patients with diabetes. So let's see what...
I cannot see your slide.
You can't see the slides?
As you have shared the screen, but the slide is not displayed.
Okay. So what can you see? Are you seeing my...
I'm seeing the Zoom browser window.
I'll close that. Now can you see?
Yes.
Okay. So let's see what we are going to talk. We are going to talk about diabetes, an elusive disorder. In spite of all the efforts, let's see where we are in management of diabetes. Change in the approach from guideline-based to a precision medicine where individual patient is taken into account, including all the factors apart from medications. We can have a structured solution to personalization, because personalization isn't easy, and it takes a long time, it takes resources, it takes tools, it takes education, it takes awareness, it takes mental health of the doctor itself. So we're going to need a direction or a structured solution to personalizing. Then only it will work, because guidelines work because they're structured. And then we'll look at the study that was conducted on personalized diabetes management called ProValue study, and see whether such an approach is going to be evidence-based or not. So we all know that diabetes is something that we are still finding elusive to get into target. in spite of all the methods or the efforts to prevention and management of diabetes, we still have the prevalence of diabetes in our country as high as 10%. So if 10 people are sitting in a hall, one of them is going to be diabetes, and we are the largest contributor to the pool of diabetes in the world. And not only that, not more than 20 to 25% people in our country have achieved the target that is known to prevent the complication in future. If we have to hypothetically, there are some trials also, but even if we consider hypothetically, if we try to take an average HbA1c of the country's diabetes, people with diabetes, I don't think it will be anything lesser than 8 to 9%. And probably this is not, this is the case similar in most of the countries, in spite of advances, in spite of technology, in spite of newer and newer medications, we are yet to reach the elusive target of less than 7% of HbA1c when it comes to averaging the patients with diabetes. And there is something called as, and often talked about as, clinical inertia, which is said to have an important, to be an important driver of suboptimal glycemic control. There are factors like there is a lack of initiation or intensification of an anti-diabetic therapy. There is always a reluctance from the patient as well as doctor's side to accept that the blood glucose has gone up and we need to initiate an anti-diabetic therapy. The anti-diabetic therapy may not be a tablet always. It may be changes in lifestyle. It may be modification in diet. It may be increase in exercise. It may be dealing with the mental stress. But there is always a reluctance of saying that, okay, this might be temporary and let's wait for some time. And then that sometimes probably never end for 2 years, 3 years, 5 years, and the patient comes with frank complications. And the patient also find it difficult to act upon the information. So many a times, because of busy schedules in the OPD, the information that is given by the healthcare professional may not be understood by the patient properly, or we may be lacking in giving a very acceptable or understandable information, which can be taken away as a take-home message and acted upon it. There are a lot of things that are needed to be clarified to the patient so that the acceptance of the information and acceptance of the advice is higher and the compliance becomes better. And that is why personalizing the management of diabetes according to the patient's individual profile, there are so many things that need to be taken into account: the patient's educational background, the patient's financial background, the acceptance of the disease, readiness to accept the treatment. Some patients are readily accepting the medication. Some patients would want to know, I don't want medication right now, I want to wait for some time. Patients who are already on medications, when we advise them monitoring, some of them have glucometers, some of them are readily happy to look at what is happening in my body and act upon the monitoring value. Some are very reluctant to even prick for a glucometer reading, or they think that the technology is too much for their understanding. So personalization according to patient's profile is very important. And that is why the guidelines have changed from a glucocentric strategy, where we are asking the patient to check, let's say, fasting and postprandial blood glucose once in 3 months or once in 2 months, for that matter, whatever frequency a patient and a doctor is comfortable with. And the patient comes to us, we look at those values, and then we change the medication and the patient goes back. It has not remained as simple as that. And now we are forming guidelines to overcome the guideline approach and to take a personal centered approach. So both American Diabetes Association and EASD now recommend a person centered approach. If you have seen the recent guidelines by both of these bodies, they have not only asked us to personalize the lifestyle management, the nutrition, the exercise pattern, but also now the previous medication pattern was also like n number of medications are given, and then it was left to the physician's discretion to choose one of them. But now we have evidences and trials which suggest that one thing might be better than the other for one profile of a patient compared to the other profile of patient. So before we choose an anti-diabetes drug, we need to choose, or we need to form a mental impression of a person's profile, and then decide one drug, one nutrition plan, one exercise pattern, one monitoring pattern, and one follow-up pattern for that particular person. So it is absolutely understandable that such an approach may not be possible at all levels of healthcare, especially in India, where there are primary healthcare settings. It may not provide you the kind of support that such a approach requires, where there is a need of a team, there is a need of a resources, there are need of technology. But what can be done is that we can choose, or we can triage patients who need such an approach, and then they can, in the beginning, they can be sent to such an approach where we find that there is a failure to achieve the target, there is a failure to respond to the therapy, there is recurrent hypoglycemia while intensifying the medications, there is drug intolerance, development of complications, or for that matter, suspicion of unusual varieties of diabetes like autoimmune diabetes, and certain mental disturbances where the patient is not able to accept the disease, pregnancy. So such are the triage parameters that we would like to identify and send such patients, or use IPDM only in such patients in the OPD, so that the management becomes easier rather than applying same thing to everyone. So as I said, that such an approach would require a lot of resources. One would be a multidisciplinary care team where we have physicians, we need nurse practitioners, we need diabetes educators, we need physician assistants, we might need diabetes educator definitely is needed, pharmacists, then we need tools like we need medications, we need delivery devices, we need people who can explain such devices to the patient. Treatment algorithms we have, so that's not a big problem. And self-monitoring glucose systems, this is also readily available, but there is a lack of understanding and explaining the use of self-monitoring of blood glucose devices in many of our patients. I've seen many patients having a glucometer, but not using it. Let's say for last 6 months, I have not used it. I don't even know whether it is working or not. I don't know whether the strips will work or not. So they're buying the tools, but they are not empowered to use them. And that is why education is very important, which may include lifestyle medication, lifestyle modification, or use of medication. Many people get confused. When should I take the medicine? Is it important to eat after taking the medicine or not? Self-monitoring of blood glucose will need a structured approach. We'll look in the next slides over it. So that is why an example is presented here, which is a holistic therapeutic approach, a 6-step approach, or a solution which is structured, given to personalization, because we may not know in front of when the patient is in front of us as to how to personalize, how to ask, what questions to ask, what are the steps to personalization, because personalization may become vague and you may not know where to start and where to end when it comes to personalization. So let's have some structured solution to the personalization, because we have discussed that every person is different, not only in terms of the profile of carbohydrate metabolism abnormalities, but people communicate differently. They want different things from life. They have different strengths and weaknesses. And when we shift our focus from treating diabetes or treating the blood glucose to treating the patient, we understand that it is important to personalize, and there are multiple factors that can be taken into account when it comes to personalization. So this the structured solution, which was tried in trials, called integrated personalized diabetes management, it incorporates 6 defined steps that are repeated in every follow-up throughout the diabetes care process. And once the healthcare team, which not only includes doctors, it is very understandable that all of this cannot be done by the treating physician. So the team once gets well versed with the steps, and then it becomes easier and less time consuming. In the beginning, it might take some efforts to establish, and we can have certain solutions titrated to our needs as well as capabilities. So at a different level of care, we can adopt different types of solutions, one of which is IPDM. A structure, the 6 steps included are structured assessment or training, For example, you can have a questionnaire, or you can have a format of a history taking, which can be done either in the pre-consultation area by an assistant or by the doctor. Then we have the treatment and the related advice of monitoring the self-monitoring of blood glucose, that is glucometer monitoring. So unless, rather than telling the patient just check your blood glucose, if you tell them that check at fasting first thing before getting up, 2 hours after breakfast, or 2 hours after lunch, or 2 hours after dinner, or at the time when the person is developing symptoms suggestive of hypoglycemia, uneasiness. So a structured way of suggesting the SMBG, and it is very useful to ask them to document those, because without documentation, person would often tell me my blood glucose is somewhere around 150, somewhere around 200. So that doesn't give any useful information about what we are supposed to do over that structured the unstructured glucose readings. So documentation is important. In IPDM, it was digitalized and all the data was entered in a system. Then systematic analysis of what we have documented. For example, there is a person whose blood glucose only drops just before the lunch. So I can advise a pre-lunch snacks in between, mid-morning snack. Or somebody who is having only high blood glucose after lunch. So I can shift the calories, or I can add a carbohydrate absorption inhibitor at the time of the lunch. So after the systematic analysis of the data that we've got from the patient, we can personalize the treatment. And what is most important at this step is to include the patient. If I tell the patient that in last 10 days or 1 month of your monitoring, I can persistently see that your blood glucose is dropping at 11 a.m., the person is very likely to accept the treatment, or he's very likely to comply to what you are telling. And then the treatment effectiveness assessment becomes very easy, because we know exactly where to look, because the person is having a problem with the glucose control exactly at 11 a.m. Next time when he comes, if that problem is sorted out, we know that the treatment is effective in its highest possible manner. So these are 6 steps which are structured, and if we have these steps in mind, it becomes easy when the person comes to personalize the treatment. So we have seen that apart from your medications, there are other aspects, that lifestyle, diet, physical activity, and all these can be structured and tailored to your clinic or your own setup, where it can make the things easy for the doctors and effective for the patient. I'm so sorry about that. Now this IPDM structured solution was tried in a trial called as Pro-Value study. And let's see what are the results. It included 907 patients from 101 study sites, and the primary endpoint was improvement in glycemic control. We don't always need a medication to drop the blood glucose. Such solutions, awareness, education can also result in improvement in the glycemic control. Not only glycemic control as a primary endpoint, but also the secondary endpoints, which include and are very important. If we only target the glucose, we may land up in a person who has a normal HbA1c but is very unhappy about the treatment, is unhappy about the healthcare system, unhappy about the doctor, and unhappy about himself. So apart from the glycemic control, we need other parameters like testing frequencies, patient-reported outcomes, the doctor-reported outcomes. If the patient needs to be satisfied, the doctor also needs to be satisfied. And what they showed was that there is a statistically significant improvement in the glycemic control in terms of HbA1c. There was improvement in persons who achieved the HbA1c in the target. There was improvement in patients who followed the behavioral and lifestyle recommendations. There was an improvement, especially in patients who are treated with insulin. I think this is a group of patients with diabetes that we need to identify as special population, which need higher education, which need higher awareness, which need higher motivation, and which need higher support, because it's not easy to manage insulin at home for the patients, because day-to-day level changes require day-to-day level improvement, or day-to-day level changes in the insulin doses, the hypoglycemia awareness, hypoglycemia, the management, empowerment to manage hypoglycemia. And that is why we can, as a first step, we can identify patients on insulin specifically to initiate the personalization of management with diabetes. Now, patient satisfaction was much better rather than just telling the patient to take the medicine. If we personalize the approach, the patient satisfaction improves, and as a result, the patient's adherence and compliance also improves. Now, it might be tiring and it might be sometimes intimidating for the doctors also to treat patients with diabetes, especially in spite of your efforts from the pharmacological, in spite of all your efforts, the patient may not get control or the patient may not be happy with the treatment. And at that point, it becomes sometimes frustrating to treat such patients. And that is why such approaches which result into a meaningful outcome not only improve the satisfaction of the patient, but also the satisfaction of the doctor. Now, in the ProValue study, when they used iPDM, they saw that the healthcare professionals could overcome errors in therapeutic objectives. They could initiate adequate treatment in a timely manner, and they could manage to intensify treatment until the therapeutic goal is achieved. The patient felt empowered about the health literacy. Patient-doctor communication was the better. They had more confidence in the doctor, and the healthcare system has a structured solution which can be easier to implement and is more outcome based. So even though we have all the technology available, even though we have all medications available, we know what to do from the diet point of view, we know what exercise needs to be done, but there is some gap over there in the knowledge that the healthcare system has, and in implementing or in imparting this knowledge to the patient where it is needed. And I think for that, such structured solutions are useful. This is one example that was tried in ProValue study, but according to our needs and capabilities, we can have such solutions in our own clinics. And that way we can approach this disease, which is kind of elusive, and we change our approach from guideline based to precision. And I saw that I have shown you that such approach needs to be structured so that it takes less time and it gets implemented in a proper manner. And one of them we have discussed, and we can have tailored approach according to the requirement. With that, I would like to thank the organizers and Roche for having such an interesting topic. I learned a lot by presenting it. And I think we have 3 minutes. So if there are any questions, we can take up. Or
Thank you, Dr. Anjali, and welcome, Dr. Chawla.
Hello, sir.
So I think a very quick question which I would like to ask Anjali is, in your own practice, what is your biggest challenge in being able to do this, and how do you overcome it? Because we are all aware and we are even more convinced after your talk. But what do we do in our clinics?
Right. So I think all of us are more or so doing it, but may not have thought of it as a structured pattern. Like we do a structured assessment. I have a structured history format, which is filled up by an assistant in the pre-consultation area. So I save time there in asking, since when do you have diabetes? What are the medications that you are on? These are the questions that can be asked by an assistant. Even a non-doctor person can ask such questions. So patient, I am in process of making it digitalized. The patient can on his iPad add those things, and we save time over there so that the quality time can be given to the patient. Then definitely we structured the pharmacological thing. We are all expert in how to choose a medication. Now we have been talking about it. But what comes after that is, again, as I said, a structured SMBG pattern is given to the patient. So when exactly the person needs to check the glucose. Sometimes patients tell you that, okay, at this point of time, I feel abnormal, without even knowing that that might be hypoglycemia, or it might be something related to gastrointestinal side effects of the medication or some other side effects of the medication. So structured pattern is given. I always ask the patient to write it down. I have patients who have 200 pages notebook with them. Since the day that they have come to me, they keep the record. It's very fascinating to look at the record a year later. When the same person comes after 1 year, and if he looks at his record 1 year back and now, it is a tremendous satisfaction for the patient as well as you to know that the things are improving. That way the patient has more compliance, more adherence, more confidence on the doctor as well as the treatment plan. And it becomes easy to convince them for treatments that are useful to them, but they're not ready to accept. Let's say after some time, if I want the patient to be on insulin, I know it's so difficult to convince the patient to be on insulin. So when we show them that there is a structured way of managing it rather than randomly assigning the medications, it definitely improves the compliance as well as outcomes.
Thank you so much.